Good morning, everyone. Today I shall discuss clinically relevant drug interactions with the proton pump. Frequently used sources and tools to identify the adverse drug-drug interactions are AGCBS criteria, which have limited utility because they are at the class level rather than at the individual drug level. Other systems tools are Micromedex Drug Interaction Checker, DrugDex, LexiInteract Drug Interaction Checker, Drug.com Interaction Checker, Intercheck Web, Epocrates, Summary of Product Characteristics monograms which the manufacturer and pharmaceutical industry provides, use of British National Formulary and the standard textbooks of the pharmacology to extract relevant information for synthesis and explanation. Apart from that, publication of individual case reports, case series, and a lot of retrospective studies are available on the adverse drug-drug interactions using two or more than two drugs. Now, as we know that adverse drug-drug interactions occur with a varying prevalence, may be common to uncommon or rare. They may be less severe, mild, or more severe. They may be serious. They may be trivial to serious to an extent requiring hospitalization. The importance is that a causal relationship has to be established between a pair of drugs. Usually it is suspected or potential, and for few drugs it is definite. Fortunately, many of the adverse drug-drug interactions are avoidable and preventable in 50% of cases. Now, many DDIs are based on retrospective studies or individual case reports, but well-planned prospective studies are a few. Clinical implication and actual relevance of any adverse drug interactions based on pharmacological knowledge remains to be standardized. At present, it is insufficiently characterized and underestimated because of gross underreporting. There could be a mechanistic explanation of the basis of drug interaction, but clinical relevance on short-term and long-term remains to be found. Now, I'll discuss PPIs, which are most commonly used drugs for the treatment and prevention of acid reflux. Now, polypharmacy is one of the most important factors of adverse drug-drug interactions, and the potential increases as the number increases over 5 or more, particularly in disorders. Now, mechanism-based drug-drug interactions can be explained as in vitro incompatibilities, pharmacodynamic mechanisms, pharmacokinetic mechanisms, we all know. It must be understood that some of the pharmacodynamic interactions are intentional and needed for better therapeutic outcome. Use of co-amoxiclav, use of ritonavir along with lopinavir as potentiating agent called as a ritonavir potentiation, use of enzyme inhibitor to inhibit the enzymes such as neostigmine. They are the desired, wanted wanted and not adverse drug interactions. Adverse drug interactions usually occur because of pharmacokinetic changes, although they may also occur with pharmacodynamic changes. An Italian cross-sectional study found that approximately 3% of the proton pump inhibitor users were exposed to potential drug-drug interaction within 1 year of follow-up. The estimate actually vary depending on the source of information on DD. Now look at the metabolism of proton pump inhibitors. They are inactivated by cytochrome 2C19. They are actually demethylated, and then also sulfone formation occurs by involvement of CYP3A4. Omeprazole is also reported to be metabolized by gut microbes in humans, and antibiotic use may actually change the degree of metabolism by gut microbes because there is a reduced activity of cytochrome 1A2, 2C19 and 3A4 of the microbe's origin. After 7-day course of the cefprozil, it may also occur with other antibiotic use. So this point can be the source of adverse drug interaction. Omeprazole-like drugs show enzyme inhibition, cytochrome 2C19. This is perhaps the most important factor for adverse drug interactions, but it may also cause enzyme induction of CYP1A2 and 1A1 particularly. Now, aryl hydrocarbon receptor is a nuclear receptor that induces expression of the genes which encode for these cytochrome isotypes. Omeprazole is a ligand for aryl hydrocarbon receptor, and this way it can induce formation of CYP1A1 and CYP1A2. Now, those drugs which are substrate for CYP1A1, for example, riociguat, or substrate for CYP1A2, a large number of antidepressant antipsychotics, theophylline, tacrolimus, tizanidine, warfarin, paracetamol, they all will be affected in this way. So, omeprazole is in focus because of several reasons. It interacts by elevating intragastric pH, therefore altering absorption and bioavailability. For example, ketoconazole and thyroxine. Thyroxine is important. And it also interacts by inhibiting cytochrome 2C19. It also interacts by induction of cytochrome 1A2. And it also inhibits organic cation transport of some drugs. Therefore, there will be adverse drug interactions because of these four. To understand how cytochrome 2C19 activity will be involved in adverse drug interactions, we should also understand that genotype variations in this enzyme will also result in a variety of the expressions, for example, poor metabolizers, intermediate metabolizers, rapid metabolizers, and ultra rapid metabolizers, and all of them there will be variation in the drug exposure and availability of blood levels of the proton pump inhibitors, making it more complicated that depending on the extent of metabolism, there will be poor activation or greater inactivation of concurrently given. In general, acidic drugs are substrates for CYP2C19 and alleles 2 and 3 are non-functional. So they are poor metabolizers. About 16% of Asians are poor metabolizers, and carriers of this non-functional gene do not activate clopidogrel. So increased risk of cardiovascular events and stent thrombosis have been reported. So much so is so important that CPIC recommends use of an alternative antiplatelet agent in place of clopidogrel, for example, prasugrel or ticagrelor in poor metabolizers and intermediate. Now, comparative PPI metabolism by biotransformation. CYP2C19 and 3A4 is involved in omeprazole, esomeprazole, and lansoprazole metabolism, but more important is that these three drugs also inhibit the CYP2C19 to a greater extent and may also induce CYP1A2. Therefore, there will be adverse drug interaction with reduced efficacy of certain drugs and increased toxicity of certain drugs. Clopidogrel activation is reduced and warfarin toxicity is increased. Bleeding. Rabeprazole, pantoprazole, elaprazole are little different. Rabeprazole is not mainly metabolized, but thioether is formed and that competitively inhibits 2C19. Pantoprazole does not inhibit CYP2C19 and elaprazole does not show such activity. Therefore, what is more important that pantoprazole and elaprazole are better drugs with use of other drugs, for example, anticoagulants and antidepressants. Now, change in the intragastric pH alters bioavailability is well known, whether it is done by H2 receptor blockers, antacids, or PPIs. And absorption of thyroxine, ketoconazole, itraconazole is reduced, but not of fluconazole or voriconazole. Therefore, these are the choices when concurrent PPI is used. Tetracycline, fluoroquinolone, cefodoxime, they all will be poorly absorbed in the presence of elevated intake. In volunteers receiving 300 mg atazanavir with 100 mg ritonavir for 2 weeks, a reduction in the atazanavir maximum level was shown by 48% and reduction in the area under curve by 62% during treatment with 40 mg omeprazole or 150 mg ranitidine. That means rise in the intragastric pH will reduce bioavailability of anti-HIV drug. This interaction is because of anti-secretory action of proton pump inhibitors. Recommendation is that PPIs and H2 receptor blockers should be avoided in patients receiving atazanavir without retinol. Omeprazole and bisphosphonate interaction. Concomitant use of bisphosphonate and proton pump inhibitor was found to be associated with increased risk of anifracture. That is important. In contrast, bisphosphonates and H2 receptor blockers versus bisphosphonates alone were associated with increased risk of vertebral fractures. Concomitant use of bisphosphonates and PPIs increased the risk of osteoporotic fractures in women aged 65 and more. And the mechanism suggested is reduced insoluble calcium absorption because calcium is not made soluble in the absence of pH as the pH increases, and there is also a reduction in bone density. Therefore, recommendation is avoid high doses of proton pump inhibitors for long time. Omeprazole levothyroxine interaction is clinically very important. Gastric acid is essential for absorption of levothyroxine. Intraluminal pH affects rate of dissolution and degree of ionization of the levothyroxine. Proton pump inhibitors reduce acid production, so markedly reduce bioavailability of levothyroxine, and treatment failure is expected in patients receiving a given dose for hypothyroidism. During replacement therapy with T4 in hypothyroidism, additional thyroid function testing must be done after the start of PPI and dose adjustment will be. This is because the T4 requirement increases as intragastric pH increases linearly. Omeprazole clopidogrel interaction is very important and has attracted the attention of clinicians across the world. Hu et al. Showed a rise from 20.8% to 29.8% in the rate of deaths and rehospitalization of patients being treated with clopidogrel for acute coronary syndrome and simultaneously with PPIs. This very important observation. This is because omeprazole inhibits sympathetic CYP2C19 and therefore it reduces the two-step bioactivation of clopidogrel, and this results in loss of antiplatelet activity. I have already stressed that 25% of Asians lack the CYP2C19 active expression. Therefore, they are at a risk of failure. A nationwide time and study, this is where it is well studied interaction. A cohort of 814 clopidogrel receivers and 407 of clopidogrel with omeprazole receivers and 230 of pantoprazole clopidogrel receivers were compared. It was found that cohort taking both clopidogrel and omeprazole was associated with increased risk of ischemic strokes as compared with the use of pantoprazole with clopidogrel. This is because the pantoprazole is less potent inhibitor of the CYP2C19. And in the same study it was found that this adverse interaction was seen greater as the duration of therapy. When it was more than 4 years, the incidence of ischemic stroke were more, and when it was more than 7 years, it was much more. So it is a duration dependent interaction. Retrospective administered databases and many other studies have also confirmed there are certain post-hoc studies of Credo trials and Triton TIMI 38 trials which did not show relevant long-term adverse outcome due to this interaction. But this interaction is important. EHA guidelines for chronic coronary artery disease in 1923 gave a boxed warning to avoid use of potent CYP2C19 inhibitors, omeprazole and esomeprazole. And current recommendation is de-prescribing PPIs according to the 2022 ECG guidelines. This is very important because there will be loss of antiplatelet activity. However, prevention of the acid-related disorder and gastric bleeding with the use of antiplatelet drugs will require some PPI. Omeprazole warfarin adverse drug interaction is well explained because PPIs inhibit CYP2C19, omeprazole more than rabeprazole, pantoprazole, and they will increase the anticoagulant action of the warfarin, particularly S-warfarin. Voriconazole omeprazole interaction is in a different way. Voriconazole reduces omeprazole metabolism, and this reduction in the metabolism is by inhibition of 2C19 by voriconazole, and this inhibition will increase the omeprazole exposure, and that will require reduction in the dose of the voriconazole so that omeprazole. Proton pump inhibitors and methotrexate is an example of interaction of these two drugs at the level of kidney. Proton pump inhibitors competitively inhibit methotrexate elimination and thereby increase methotrexate level and possible methotrexate toxicity on bone marrow. The mechanism remains to be elucidated, but there is an inhibition of breast cancer resistant protein transport of methotrexate in proximal tubules. So there is reduced tubular secretion and greater amount remains in the body. And as we know, BCRP is involved in ATP-dependent efflux of methotrexate. Therefore, carrier transport function is inhibited. An important interaction is observed as hypomagnesemia when there is a concurrent use of proton pump inhibitors and thiazides. And this is explained by poor absorption of magnesium by proton pump inhibitors alone by inhibiting epithelial transport of the magnesium required for absorption, and there is a 43% risk of hypomagnesemia. Therefore, monitoring required even when PPI is given alone. However, when thiazides are combined, thiazides do cause magnesiuria, but the risk is low. But when we combine PPI and thiazide, there is a theoretical risk of greater hypomagnesemia leading to cardiac arrhythmias. It has also been observed that thiazides induce hypercalcemia may mask hypomagnesemia, and you treat this, hypomagnesemia will be evident. An important outcome of this interaction of PPI with thiazides causing hypomagnesemia is the risk of chondrocalcinosis. Hypomagnesemia is associated with chondrocalcinosis because magnesium increases solubility of calcium pyrophosphate dihydrate crystals. So, in magnesium deficiency, these crystals are deposited in the joints, leading to pseudo gout or chondrocalcinosis. PPI use and metformin. This anti-diabetic drug, perhaps the most frequently used drug, and also omeprazole is very commonly used. So there is an interaction, and the interaction is that 15 to 20% increase in the metformin exposure occurs in the presence of omeprazole and rabeprazole because proton pump inhibitors inhibit hepatic, renal, and intracellular uptake of metformin by inhibiting organic cationic transporters 1, 2, 3 in all these three organs. Individuals with reduced functional allele of organic cation transport 1 may exhibit higher levels of metformin that may have also acidosis. So the potential interactions of proton pump inhibitors on metformin pharmacokinetics are well elucidated, and it occurs at stomach level, at intestine level, at liver level, and at kidney level, and the main transporter function inhibition is the underlying. Now, concurrent use of metformin with PPI may also lead to a risk of vitamin B12 deficiency, particularly those who are vegans and their diet is deficient in vitamin B12. PPI alone have been reported to cause a 65% increased risk of vitamin B12 deficiency. Metformin alone is also reported to decrease B12 absorption by 20 to 30%. Mechanism underlying is that HCl is needed for release of vitamin B12 from dietary proteins, and lowering level of transcobalamin 1 rather than B12 malabsorption by metformin is the cause of B12 deficiency. However, when these two drugs are used combined, there is always increased risk of vitamin B12 deficiency, and some researchers recommend the monitoring and consider B12 supplementation. Other interactions with omeprazole are a few. Omeprazole reduces clearance of diazepam, phenytoin, and warfarin. Diazepam clearance is reduced because it inhibits the demethylation of diazepam at a dose of 20 mg. Therefore, there is a 30% increase in the half-life of diazepam. So, increase the sedative effects of the diazepam. Omeprazole increases clearance of antipsychotics and theophylline by inducing cytochrome 1A2, and therefore it may lead to adverse effects of antipsychotics with concurrent use. Omeprazole slows metabolic inactivation of citalopram, just like clopidogrel. So increased risk of QTC prolongation is there. Lansoprazole, to a lesser extent, pantoprazole does not show such interaction. Conversely, clarithromycin inhibits omeprazole metabolism, so increases omeprazole blood levels. Increased healing rates have been reported, but increased adverse effects have also been. Therefore, when we use more than two drugs, we must observe utmost caution, and it is here that there is a role of P drugs. Physicians should consider a limited number of drugs as P drugs of which they know the best before prescribing. Proton pump inhibitors will continue to be used for a variety of indications, and therefore we must be aware of the adverse drug-drug interactions and how to prevent them. Thank you.